We'll just wait a few more minutes for everyone to join and then we'll start with the class. Meanwhile, you can tell me if the screen is visible and if I'm audible. Okay, I think we'll start now. So good morning, everyone. So today's topic is the examination of strabismus. And as far as I know, most of your topics have been covered most of the squint has been covered in theory classes by Dr. Das sir. So we'll be briefly going over the examination, and towards the end, we'll watch a few videos for demonstration as to how to do a few tests that are specific to strabismus examination. So yeah, what relevant history that comes, that you need to ask when you are examining a patient of squint or a patient of squint approaches you. You have to ask the patient for the age of onset of deviation, okay? So this can be either a congenital thing, right? Or it can be acquired over the years. So, when you know the age of onset of the deviation, you'll be able to categorize the squint into two. It can be either congenital or acquired, right? So then you need to ask the patient next is whether the deviation is constant or intermittent. Again, this is to categorize or come to a diagnosis or be able to localize as to where the pathology could be, right? And then you have to ask whether the deviation is present for distance or near or for both. Now again, that tells you a lot about what could be the possible etiology of the deviation, right? Or if it is unilateral or alternating. Okay. Then you also have to ask for any factors that could exacerbate the deviation. When the patient is inattentive or fatigued, the fusion mechanism is lost, and the person might be manifesting the deviation more when the person is inattentive. Then you have to ask for other symptoms like asthenopic symptoms or headaches if the patient is experiencing, and diplopia. The patient themselves would come to you with diplopia. You need not, try to elicit this history. It's going to be very disturbing, and they might just tell it to you themselves. Then other than that, you have to ask for a history of association with trauma, right? So then you could be ruling out paralytic causes and things like that. Birth history is very important, and also family history of strabismus if it is present or not. Now, the first and foremost things that we need to do when any patient of strabismus comes to us is visual acuity. It is very, very important. We've dealt with how to take visual acuity in the previous classes, and you have to make sure that the patient undergoes refraction. Okay. So, beginning with squint per se, what you need to inspect is uh, that whether it's, when you're just inspecting the patient, you will come to know a lot of features of the squint, whether it's constant or intermittent, alternating or non-alternating, whether any anomalous head position is present. And then you check for fixation of both the eyes separately and together, and, visualize whether, it's maintaining the fixation or not, or if at all, if there is any obvious nystagmus that is present. Okay. because if nystagmus is present, that means the patient is going to have a very poor visual prognosis. And then the first and foremost thing that we need to see is you have to rule out that whether there's a pseudostrabismus present. So what is a pseudostrabismus? It's a false impression of a manifest squint. It can be either types. It can be a convergent or a divergent pseudostrabismus, right? So these are few examples. So over here you see that this appears that the eye is inside, like it's deviated towards the nasal side. Now this can happen because of, I told you in the lid class that these folds, the extra loose folds of skin that come from the upper eyelid below, those are called epicanthal folds, right? So these folds, they can mimic a mimic an esotropia. And also a short interpupillary distance can give that picture, and a negative angle kappa. Can anyone tell me what is angle kappa? And I want some other people to answer this time, other than the ones who usually answer. If you guys don't answer, like if all of you don't answer, then I'll have to ask roll number wise. So anybody who can tell me what is angle kappa? Okay, I want roll number 10 to answer. Yeah, Adarsh, Anukriti, Nikhil, Saksham, all of you are right. It is the angle between the pupillary and the visual axis, correct? All right. So patients who have a negative angle kappa, they may present as a pseudo-esotropia. Now, what is a pseudo-exotropia? Over here, you can see in this patient, the right eye seems deviated outwards. This can also be a pseudo manifestation in patients who have a wide interpupillary distance or a positive angle kappa. Now, what are the characteristics of a pseudo squint? They'll usually be presenting in children and it will disappear with age. And it does not show any deviation under cover. I'll tell you how to do cover and uncover and alternate cover tests. These pseudo squints, they will not show any deviation. Okay, and they will disappear if, for example, if it's present with an epicanthal fold, it will disappear when the epicanthal fold is obliterated. And you can obviously measure the angle kappa. Okay, you can do it with the synaptophore. There are objective and subjective methods to look for angle kappa. Now, one very basic test to assess small children, or very quickly screen patients, is a Bruckner's test. Now, this is an objective test. The only thing that it requires is a direct ophthalmoscope. And a Bruckner's test is considered positive when there is asymmetry of brightness of red reflex in the pupillary area. So you know that you're supposed to look for a red reflex in pupillary area, and in a normal patient, in a normal person, it'll be equally bright in both eyes, right? But it's considered positive when there is an asymmetry. Okay, so the eye that is squinting eye, that will show a brighter reflex. I'll show you an image in the next slide. So over here you see that in the left eye of this child, the child probably has an exodeviation in this eye, and if you look at this shows a brighter red reflex. Okay, so this test is actually only used to screen the patients very quickly, or if there are very small children, they'll not follow your commands, so you can easily screen patients for strabismus in uh, children. Then the other screening test is your corneal light reflex, or a Hirschberg's test. What it does is it measures the relative position of the light reflex on cornea. What you have to do is just ask the patient to look straight ahead and shine a torchlight from the front, okay, at the level of the pupil. And then you look for the position of the corneal reflex, okay, in relation to the pupil. So any amount of decentration that is there, you're supposed to note it. And any, a single millimeter of decentration of the reflex, that corresponds to 7 degree or 14 prism diopters of deviation. Okay, and if the reflexes are symmetrical, obviously there is no squint. And what happens is when the eye is deviated inwards, the corneal reflex formed from that torchlight will be deviated outwards. Okay, so if the eye is esotropic, the corneal reflex will be formed temporally. And if the eye is deviated, then the corneal reflex will be formed nasally. All right. And coming to Hirschberg's test, I've already told you all this. Now you can see these pictures. In this, the right eye of the patient is turned nasally. That is, it is esodiviated. So you can see that the corneal reflex is more towards the temporal pupillary border, right? So if it reaches the pupil, the border of the pupil, the deviation is approximately 15 degrees. Over here in the other picture, you see that if it's at the limbus, okay, here in the other eye, in the left eye, you can see that the corneal reflex over here, it is quite centered. Although here also it looks deviated superiorly, but if you look into the other eye, you will see that the corneal reflex is at the limbus. Okay, so if it's at the limbus, it is considered to be a deviation of 45 degrees. If it's between the pupillary margin and the limbus, then it's a deviation of approximately 30 degrees. So this is a rough estimate that you can make. Now again, you can see over here that in a normal person, it will look symmetrically, almost centered. In a patient with exotropia, the corneal reflex deviates inwards, and in a patient with esotropia, it will deviate outwards. Okay, now a few more questions. Can anyone tell me what is a primary deviation? Okay, so a primary deviation is when we ask the patient, if we are shining torchlight from the front and we ask the patient to fixate on this light. Now, there'll be one eye that will, if the patient has a manifest squint for that matter, one eye is going to be the fixating eye, okay? And the other eye is going to be the squinted eye. So when the person is fixating from the normal eye, the squinted eye is going to be either eso or exotropic. So that deviation of the squinted eye is called the primary deviation, okay? Now, when you make the patient fixate from the abnormal or the squinted eye, the deviation that you will see in the normal eye is the secondary deviation. Okay, have you guys understood what I said? Or do you want me to repeat? I'll show you, I mean, I'll explain, yeah, with this example. One second. Okay, yeah. So here you see in the first picture, this picture here, the patient has a right esotropia, okay? The right eye is deviated inwards, all right? And the left eye appears to be, for example, if we are standing in front of this person and shining a torchlight, all right? So the left eye, with the left eye, he's fixating, the right eye is deviated inwards, all right? So now what is happening is this left eye, which is normal, is fixating and the other is inwards. So the deviation Yeah, can you hear me now? Okay. I'll restart from primary and secondary deviation, okay? Yeah. So what I was saying was in primary deviation, the fixating eye is the normal eye and we are measuring the deviation of the squinted eye, okay? And in the secondary deviation, now we are making the squinting eye fixate, okay? And we are measuring the deviation in the normal eye, which has now undergone, uh, which has now basically deviated from its normal position. Did you guys get it now, or should I repeat once again? Okay, so then we'll proceed. Yeah. So basically the examination of squint is divided into two parts: the evaluation of the sensory adaptations and the motor adaptations. Okay. So in the motor evaluation, we're going to look at three things first. One is the head posture, the other is the extraocular movements, and then the cover tests. Okay. So abnormal head posture can be either of these three things. Either they can be a face turn, which is usually seen in a horizontal muscle involvement. Okay. And there can be a chin up or a down position, which can be seen in a vertical muscle involvement, or there can be head tilts, okay, which is seen in oblique muscle involvement. Or if at all there are multiple nerves or muscles involved, then it can be a combination of all these three. Right. So we look at this one example over here. Now you look at this picture first, okay? Like look at the position of the head. Can anyone tell me what is the abnormal head position? What kind of abnormal head position this is? Yes, it's a face turn, but to what side is the face turn? Correct. It's a right face turn. So now looking at this person, what we can understand is the patient over here. Look at this. This is an example of a sixth nerve palsy, okay, of the right eye. Now in a sixth nerve palsy, what does the sixth nerve supply? Which muscle does the sixth nerve supply? Perfect. It supplies the it supplies the lateral rectus. Correct. So now the lateral rectus is paralyzed. All right. So the eye is not able to get abducted. So it is deviated inside, okay, or to the nasal side or esodiviated, right? So now this eye is not able to go out, but we have to maintain binocular vision. Otherwise, in this eye, the image is not forming on the fovea, but in this eye, the image is forming on the fovea. Now the patient will complain of diplopia. Now, to avoid that situation, what this patient will do is that this eye is here only, so they'll move the other eye, that's the left eye, in that position, so that both the eyes obtain an image on the fovea. All right. So now what he's going to do is, now when he's obtained this position, this abnormal head position, now even this eye is over here, and so is both the eyes are now in levo version. Okay. So now he is going to be able to, like maintain foveal fixation of images from both the eyes. So do you understand how is a compensatory head posture attained? Okay, I'll explain again. Now, what is happening if you see the patient has had a face turn to the right, all right? So both his eyes are moving towards the left. So now the patient is actually in a state of lever version, all right, when he's attained a position where the head is turned to the right. Now, why is he doing this? That's because, for example, like his sixth nerve is paralyzed, right? So he's not able to abduct the right eye. So the right eye is either adducted or esodiviated. Now the other eye is normal, that can move either nasally or temporally. But now the problem with the right eye is that cannot go temporally. So to be able to, now this abnormal eye will not have a foveal fixation, but the other eye will have a foveal fixation. Now that will lead to diplopia. It's going to be very uncomfortable for the patient, right? So what they'll do is because ये तो नहीं हिलेगा, but this one can still move. So they will move the left eye, you know, temporally, right? So they will abduct the left eye. So they'll attain a position like this that you see in levo version. So now since both the eyes are in the same place, both of them will be able to fixate the object of regard on the, and there'll be a foveal image that will be formed. So that problem of diplopia will disappear. All right, have you understood it now? Okay, good. So then we'll move further from here. Okay. Now, how do you evaluate the motility? Is that, do you know what are ductions and versions? Yeah. So ductions are uniocular movements or monocular movements, and versions or vergences are binocular movements. Okay. So in a patient of squint, we have to evaluate these as well, right? So along the horizontal axis, what is going to happen? The eye is either going to elevate, okay, or it's going to depress, right? So that is elevation, this is depression. So figure A is elevation, figure B is depression. This is what we're talking about of monocular eye movements. Along the vertical axis, what can happen is either the eye can go nasally or temporally, right? So if it is going temporally, that means that is abduction of the eye. When it's going nasally, that is adduction of the eye. All right. Or for that matter, the eye along the anterior-posterior axis, it can either intort, okay, and that is encyclotorsion, or it can extort, okay, when it's going, when the superior limbus that goes outwards, that's called extorsion. When the superior limbus that goes inwards, that's called intorsion. All right. So when the eyeball rotates inwards, that's intorsion. When the eyeball rotates outwards, that is extorsion. Right. Similarly, we have binocular movements that are present. Okay, binocular movements comprise of versions and vergences. Now versions are the ones that happen in the same direction. For example, levoversion, that is when both the eyes are looking towards the left, and dextroversion, when both the eyes are looking towards the right. Vergences, whereas on the other hand, are the opposite movements, okay, or the disjugate movements. So that is when, for example, in this last picture here, you can see that this is convergence. So when both the eyes are moving in opposite directions, both are moving nasally, right? So that is convergence. So you have to, you know, evaluate the extraocular movements in all the 9 gazes to be able to come to a diagnosis. It's very important in a case of squint. Now we come to the next part, which are cover tests. Okay. Now cover tests can tell you a lot about the kind of squint, whether it's a latent squint or a manifest or a pseudo squint or a true squint, whether it's concomitant or a paralytic squint, whether it's uniocular or alternate, constant or intermittent, whether it's for near, whether it's a squint more for near or distance. Other than that, it can also tell you about the magnitude of the deviation, right? So we'll go to cover uncover tests first. Okay. So what the patient does is the patient will fixate on an object, which is far out. Usually we take what the Snellen's 6-9, the line that corresponds to the 6-9 vision, that line we take for fixation. And the apparently normal eye, for example, the patient has come to you with left eye which is deviated outwards. Okay, so what we'll do is we'll cover the right eye first. Okay, and then we are going to see the movement of the squinting eye. Okay, whether it, first of all, whether it takes up fixation, and if at all, if it is taking up fixation, whether it is central, whether it is steady, whether it is maintained. Okay, this fixation has to be looked up in 3 aspects: whether it's a central fixation, whether it is a steady fixation, and whether the person is able to maintain that fixation. All right. So now once that eye has moved to take up fixation, now for example, the patient had the left eye in exodeviation, or for that matter, yeah, the left eye is deviated outwards. So which direction do you think the eye will move to take up fixation? Correct. So when the eye is deviated outwards to take up fixation, it has to come nasally or it has to move inwards. So that is what the next two lines explain, that if the eye is moving out to take fixation, that means that it was already inwards and it has to move out to take up fixation. Similarly, an eye that is deviated outwards or is an exotropic eye, it will move inward to take up fixation, right? So that is uh, the basis for cover uncover test. Now what happens is in the non-fixing eye, when that is covered, what will happen? It will either show no movement. Sorry, if one second. Yeah, if it shows no movement, that means the squint is unilateral. Okay. And if the fixing eye deviates under cover, that means when the squinting eye is taking up fixation, the eye under cover remains deviated when the cover is removed. And that denotes that it is a case of an alternate squint. Okay. We'll see one video over here for you to understand this better.
Have the patient look directly at a target at least 10 feet away. Cover the left eye and watch for a movement of the uncovered eye. Repeat this step a few times. Then do exactly the same thing in covering the right eye. If no movement occurs in the uncovered eye, the eyes are aligned. Here is a patient with esotropia. The left eye is deviated inward. As the fixating right eye is covered, the left eye moves outward to pick up fixation. As the non-fixating left eye is covered, there is no movement of the already fixating right eye. Here is a patient with exotropia. The left eye is deviated outward. As the fixating right eye is covered, the left eye moves inward to pick up fixation.
So you see that you in cover uncover test, the first thing that you do is you cover the eye that is apparently normal. Okay, so over here the left eye was exotropic. What you were trying to do, the first thing that you did was cover the apparently normal eye. Okay.
Fixation.
Now you see that the eye is moved inwards
As
to
the
take up fixation.
non-fixating left eye is covered, there is no movement of the already fixating right eye. Here is a patient with a left hypertropia. The left eye is deviated upward. As the fixating eye is covered, the deviated left eye moves downward to pick up fixation. As the non-fixating left eye is covered, there is no movement of the already fixating right eye.
Yeah. So did you people understand how to do a cover uncover test? Okay. So which eye do you cover first while doing a cover uncover test in a patient who has a manifest squint? Perfect. So you cover the apparently normal eye first. And then what will you see? For example, there is a left exo deviation. Okay, then what will you see? What will happen to the left eye if we are covering the right eye, which is apparently normal? Perfect. So the left eye will move inwards to take up fixation. What all are the three characteristics of fixation of an eye that comes to take fixation? What should you notice? Or what should you, like take note of? Correct. You should look for whether the fixation is central, whether it's steady and it's maintained. Okay. And what happens to the eye that is under cover? The eye under cover will undergo deviation, okay, because the other eye is coming up to take up fixation. So what happens according to the laws? What is Herring's law? Do you know what is Hering's law? Yes, correct. So because equal innervation is going to go to them, the other eye is also going to deviate under the cover. Okay. But okay, somebody is asking, why is secondary innervation more than the primary innervation in the case of paralytic muscle? Why do you think so? This particular law explains it all. So because innervation is going to go even to the paretic muscle. Okay. And for example, if the right lateral rectus is paralyzed. Okay. So just one second, I'll explain this and I'll explain the normal eye wala phenomenon again to you. For example, if the right lateral rectus is paralyzed, now the right eye is not able to abduct. Okay. But in case the patient wants to perform dextroversion, what will happen is that the left eye will adduct. Okay. But the right eye is not able to abduct at all. But innervation is going there also, right? So because it's not able to, there'll be an excessive innervation that will go to that eye in the paretic towards the paretic muscle, and hence there'll be an exaggerated response of the yoke muscle of that particular paretic muscle. That is why the secondary deviations are more. Nikhil, I'm not understanding what is your question. What will happen to the normal eye? Which normal eye? And in what situation? When we cover normal eye in cover uncover test. Yeah. So what happens is this squinting eye will move to take up fixation. Okay, when we're covering the normal eye, the squinting eye will move either inwards if it's exotropic or outwards if it's esotropic to take up fixation. That is what happens. But under the cover, because of this movement of the squinting eye and because of the Hering's law, the normal eye also under the cover would have moved or deviated from its position. All right. Okay, we'll come to the rest of the examination part and I will deal with the questions later. Okay. Okay, so alternate cover test. So in this test, what we do is one of the patient's eye is covered for a while. Now, earlier we were only covering one particular eye and then uncovering. And then eventually going to the other eye, covering it and then uncovering. But in an alternate cover test, what we do is we keep covering one eye after the other, and we just like cover the eye for 2 to 3 seconds and then move to the other eye and then cover that eye for 2 to 3 seconds and move back to the first eye. Okay, so that's how you do an alternate cover test. Now the process of covering alternate eyes is continued and you watch for any movements, okay, as the cover is moved. Now what does it give you is that it gives you the direction of deviation, the amount of deviation, and also the speed of recovery. All these three things are very important when you're looking for the movement. So again, I'm going to show you a video on how to do a cover uncover test and also an alternate
Hello,
cover
and
test.
welcome to this demonstration of how to test for phorias, both esophoria and exophoria. Now, as we saw in the previous video, cover testing is ideal to look for tropias, manifest deviations, whereas phorias are only picked up by cover-uncover testing and in extreme cases by the cover-uncover test. Let's demonstrate here. We will cover this patient's left eye and we see absolutely no movement of the right eye, and when we uncover there is again no movement of either eye. Let's repeat the same procedure with the right eye. We cover the eye, nothing. We uncover the eye, and again there is no movement with this uncover test of either eye. It must be said, however, that in extreme cases where the phoria is quite marked, the eye will likely deviate simply using the cover-uncover test, but not in this particular example. The alternate cover test is what is needed, and this will be demonstrated thus. We move the occluder from one eye to the next, not too quickly. It's important to linger for a short while to dissociate the image in the brain.
So now you see that the eye is moving from inside to outside to take up
Seen in this
fixation.
particular case, As the eye is uncovered, the eye flicks outward. Both eyes flick outward. This is the breaking down of the foria. Now this is an esophoria as the eye is flicked outward. Now we will demonstrate the same phenomenon with an exophoria, in which the eyes are held together when both are open, but when fusion breaks down due to the cover-uncover test, we will see what occurs. So we cover the right eye again, nothing. Uncover, nothing. We repeat the procedure as we always should on the contralateral eye. Cover, nothing. No movement at all. Uncover, nothing. And now we again perform the alternating cover test. Swing very carefully, back and forth. Now we see the eyes flick in as opposed to flicking out. Therefore, when fusion has broken down, the eyes drift outward, and this term is called an exophoria. And this can be nicely demonstrated by this software. Thanks for listening.
All right. So did you get how to do alternate cover test?
Hello and welcome.
Okay, moving on to the sensory evaluation, there's just one test that I'm going to deal with, although there are multiple. For your level, we'll only do with this one or two tests. Okay, so this one being the Worth 4-dot test. It's a self-illuminated panel which has two green, one red, and one white light. Okay, so this is what this block that you see in picture A is the one that it looks like. So there are two green lights horizontally over here, one red light on top and one white light. All right. So they're arranged in a diamond pattern, and the test is generally done at 6 meters. Or if you have a flashlight which has these four dots, then you can do it at 1 meter also. Now, for this, the patient needs to have a fairly good vision, and you have to make sure that the patient has put on the best corrected glasses. All right, and the patient wears a red-green glass, where the red glass is in front of the right eye, which is by convention. Over here also, and when we do diplopia charting, there also. So red for right, R for R. So the red glass is worn in front of the right eye. Okay, and the green goes for the left eye. So when the patient looks through the red glass, he can see the spot. First of all, he'll obviously be able to see the red spot, and the white spot that is there, that will look slightly pinkish. Okay, and when the patient is looking only through the green glass, he'll obviously be able to see all the green images, whereas the white spot, it will look light green, right? So this is how normally a person who has a normal binocular vision, that's how this is going to appear. So there's going to be one red spot, two green spots, and slightly pinkish spot at the bottom. Okay, can anyone tell me what is picture C? Because I know that you all have taught what is suppression and things like that. What kind of a patient will present with the image that is shown in C? Yes. So, Adarsh, you're right. It's going to be because of suppression. Mayank, you're also right. But Mayank, what suppression will cause you to see only red lights? Correct. So it's going to be when the left eye is suppressed, that is where you're going to perceive whatever you can see from the right eye. So you'll only be able to see that red dot, which is already being visualized by the right eye, and the white dot, which turns red. Okay. Now, somebody tell me what is the interpretation of the image D? Absolutely right. So that is right eye suppression. Can also someone tell me what is the interpretation of E? Correct. So there is an extra image that the person can see here, all right? There are ideally only supposed to be four, but what this person can see is definitely something extra, right? So there is a diplopia that is present in this person. All right, so we'll read the interpretations. So when a normal One second. When a normal patient looks with both eyes open, there's going to be two green, one red, and a mixture of red and green. If there's a left suppression, they'll only see what the right eye can see, and the right is for red, and they'll only be seeing two red lights. Whereas in the case of right suppression, they'll only see with the left eye, and whatever is seen by the left eye, you're wearing a green glass in front of it. So they'll be seeing three green lights, two of the normal green that was present, and the white light will also appear green to them. Then in the presence of an ocular deviation, when the patient has diplopia and normal retinal correspondence. Can anyone tell me what is a normal retinal correspondence? No, I'm asking you what is normal. Others, what you're telling me is abnormal retinal correspondence. Quick, 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 quick. Yes. So when the eyes, the images are falling on the corresponding points, okay? That is, and the patient has an ocular deviation, he'll be able to see five lights. And if a patient has an ocular deviation but anomalous retinal correspondence, that means now the foveal and the extrafoveal point, they are anomalously corresponding, whether normally they shouldn't have been corresponding points. But now, because there's an anomaly, they are corresponding. So what is happening is that patient is not able to appreciate that extra fifth image. Now he's only seeing four spots. Okay, even though there's an ocular deviation present, now he's only seeing four spots. Correct? Has everyone understood? Great. So yeah, the last part of the session is diplopia charting. Okay, now this is very important. Okay. Yeah, I'll repeat the last interpretation. What I was saying was, see, a person, first of all, what is normal retinal correspondence? So the retina, what it has is, it has various points in each eye. Okay, so the right retina, the points on which the image would fall has corresponding points in the left eye. Okay, so when both the images are formed on the corresponding points, the patient will not have diplopia, even if there is a deviation present. Even if there's a deviation, but the image still forms on the corresponding points, they will not have diplopia. Okay, sorry, they will have diplopia when there is an ocular deviation. Because now on one eye, it will form in one particular plane, and the other eye, which is deviated, the image will form at another particular point. And now these points are not corresponding. Okay. So in that case, the patient will have diplopia, and then the patient will be able to see these five dots. But in case the patient has an anomalous retinal correspondence. Now by anomalous, I mean that in one place, the image is formed on the fovea, and in the other place, it is formed extrafoveally, but that is anomalously correspondent to each other. Okay, they are acting as correspondent points, even though they are not. One is an extrafoveal point, one is an extrafoveal point, but they are anomalously corresponding to each other. Now, if they are corresponding to each other, then the patient will not have diplopia. He'll still be able to see four images and not five. Now, is it clear? Okay, perfect. Then we'll go to the last part, which is diplopia charting. So by diplopia charting, what all you should figure out when you have made a chart is whether the diplopia is crossed or uncrossed. What is the direction of gaze where the diplopia is maximum? To which eye is the paretic muscle belonging? Okay. And which muscle of that eye is involved? So these are the four interpretations we must have by the end of our diplopia chart. So again, the patient wears a red-green glass. Okay. Red in front of the right eye, which is by convention. A bright and sharp white streak is used to plot the chart. Okay, so on a screen, or you flash the streak, and you make the patient stand, and again you make them use red green diplopia glasses, and you make sure that the head is in normal position. For people who come up who have tendencies for an anomalous head position, you have to make sure that they are standing erect with a normal head position. Now, for a patient who does not have any diplopia, they will either see two streaks which are of the same brightness, which are almost overlapping each other in all the 9 quadrants. So what you do is you draw quadrants on that screen, or on the like whichever screen that you are doing your diplopia charting in. You either draw quadrants on it, or you make them analyze in all the 9 gazes. And what will happen is, in a normal patient, they will not have diplopia. They'll be able to see two streaks which are equally bright or almost overlapping each other, right? Now, in case of diplopia, what will happen? There'll be a separation between the two. So the patient will see a very like a sharp image, and the other image that he's able to see because of diplopia will be a blurred one. Okay, so now these images, they'll be separated from each other. Now they can be separated either horizontally or vertically, or there may be tilting of one image. All right. So the direction of separation will give you a clue as to what muscles are involved, right? So if there's a horizontal separation, you will have a clue that, okay, it's mostly going to be a involvement of either the medial or the lateral rectus. If it's a vertical separation, like purely vertical separation, then you'll know, okay, superior or inferior recti are involved. If there is tilting, then you know that there is involvement of the obliques. Okay. Then so yeah, the false image is the one that is the blurred image, okay? That is formed in the deviated eye at a point other than the macula. So it's blurred compared to the true image. Now the distance between the true and the false image may vary at different positions of the head and the gaze. But we are fixing the head, so we're going to check for the deviation only with the changes in gaze. All right, so what will happen is, what we have to look for is the maximum separation. Okay, so the image that is more peripheral and blurred, it actually belongs to the paretic eye. So you will get to know which eye is involved by looking at the image that is more peripheral. So you'll know which eye is paretic. Okay, now the separation of two images is maximum in the field of action of the weak muscle. For example, there's a patient who has right lateral rectus palsy again. Okay, so the maximum separation will be seen in dextroversion. When the person is looking in direction of the paretic muscle, that is where in that gaze the patient will see maximum separation of two images. Okay, so you have to find out the direction of gaze in which the separation is maximum. That is the task in diplopia charting. Okay. So now, for example, in vertical diplopia, you have to find out which muscle is there, whether elevator is the one at fault or depressors are the one at fault. Okay. Then in case of vertical diplopia, you also need to find out whether there is a maximum separation during abduction, which will tell you the recti are involved, or the maximum separation is during adduction, which will tell you whether obliques are at fault. Okay. Now, cross diplopia is usually by the paralysis of adductors of the eye, that is the medial rectus, superior and inferior rectus. Can anyone tell me what is cross diplopia? Yeah, but it is definitely seen in exotropia. But what does the term cross diplopia mean? Correct, correct. Absolutely right. Okay, so what normally we would see is, but again, I'll take the example of right lateral rectus palsy. Now, in that case, what would have happened is that the blurred image would be towards the right. Okay, you'll see a red image and a green image. All right, but if it's a right lateral rectus palsy, the blurred image will be towards the right. Okay, but what happens in cross diplopia is that the image that you're supposed to see from the right eye, the blurred image, that will cross over to the other side. All right, and that happens when there are palsies of the adductors. And in uncrossed diplopia, that's usually caused by the paralysis of abductors of the eye, for example, lateral rectus, superior and inferior obliques. All right. Now we'll see just a few examples before we come to the end of the class. So over here you see that this is when the patient is looking towards the left, this is when the patient is looking towards the right. Now what we see is, okay, in primary gaze, there's not much deviation. Maximum deviation is happening when the patient is looking towards the right, right? So now I told you that the farther image is the one that belongs to the paretic eye. All right. So the farther image is green, and green belongs to left. So what eye is involved over here is the left eye. Okay. So that tells you that when the patient is looking towards the right, that means when the left eye is adducting, or when the medial rectus is supposed to function. Now the patient is getting maximum separation between these images. That means when the left eye is supposed to adduct and when the left medial rectus is supposed to function, there is diplopia. That means the left medial rectus is involved. Okay, that is how you interpret a diplopia chart. Now over here, when you see the second image, now maximum separation is occurring. There's a horizontal separation and there's a maximum separation that is occurring towards the left. And again, the farthest one, the one that is more in the periphery, is the one that is the left image, right? The green image. And green belongs to left. So there's left eye involvement for sure that we've established. Now, which muscle of the left eye is involved? Now you see that it's in the levo version, when the patient is looking towards left, that is when the maximum horizontal separation is occurring, right? So in levo version, the left eye is supposed to abduct, or the lateral rectus is supposed to function, right? So because lateral rectus is not functioning, the maximum separation is occurring when the patient is performing levo version. All right. So by this we interpret that the left lateral rectus is involved. Is that understood? Okay. I'll explain once more. So when we're doing a diplopia chart, what do? We just you know make a flashes. There's a screen which will be divided into these quadrants. There are 9 quadrants. Okay. Now the patient is in front of you. The patient is in front of the screen wearing a diplopia red-green glass. Okay. So now he's going to be able to see a red image and a green image. Okay. The red image will be in front of the right eye. The green image will be in front of the left eye. So now in the center over here that you see, what you're supposed to ask the patient is you have to ask them whether there is any diplopia that they see. Okay, and when you change the direction of gaze, whether the deviation increases, in which gaze is the deviation increasing, and where is the deviation maximum. Also, you should ask if there is any tilt or anything like that. Okay, and you should always keep checking which image is the one that is more peripheral, or which is the image that is more blurred. Okay, now what is happening in the first image is that over here there is not much separation. Okay, the maximum separation is happening when the patient is looking towards their right. Now, and the farthest image is being formed by the green color. If you see, the green is the one that is more in the periphery. All right. So first of all, we've established that the image that is formed more peripheral is the one, that image belongs to the eye that is involved or paretic. Okay. So because it's green here, that means the left eye is involved. All right. So we, at least by that, we've established which eye is involved. Now for that eye, which muscle is involved? For that, you have to look for the maximum separation. Now we're seeing that the maximum separation is occurring when the patient is trying to do dextroversion. Okay. So in dextroversion, there is maximum separation that is occurring. So in dextroversion, what is the left eye supposed to do? It is supposed to adduct, or the left eye ka medial rectus is supposed to act. Now, because that is not acting properly, which is why we are able to see over here that the maximum separation is in that particular gaze. So because it's in levo version, medial rectus was supposed to function, not functioning, so medial rectus is involved. Understood? Okay. Perfect. So Anukriti, this is not Maddox rod test beta. This is a diplopia chart. We just like put a streak of light on a screen, on a white screen. That's it. This is not Maddox rod. Maddox rod is separate. Okay, we'll see just one more example. Now again, this is slightly more explanatory because you can see the read out the explanation on the side. Now, what is happening over here? You see that from left to right, the separation is increasing, with the maximum being in, again, dextroversion, right? So this is the example pretty much which, and over here, the farthest image, if you see in comparison to the other one, the farthest image or the more peripheral image belongs to the right eye, because the farther image is being formed of the red, by the red glass, okay? So that tells you that the right eye is definitely involved. All right, and it's maximum in dextroversion. That means the right eye was supposed to be abducted. That means the lateral rectus was supposed to function, but it's not. So now you've established which muscle is involved. You've established the eye, you've established the muscle. And that is the aim of diplopia charting. That's how you interpret the charts. Now the last thing is force duction test. Now this helps you to differentiate paralysis from restriction. Now in adults, how you do it is this test is usually done under local anesthesia. You just put a few drops of xylocaine and it'll be done. And in children, it'll be done under general anesthesia. Now what happens is in this, what you do is once you've put the anesthesia and the patient, basically you make the patient outstretch the hand and you make them look at their thumb, okay? By the direction of the thumb, you'll basically be asking them to look in that particular direction. Now the eye, it's grasped with a toothed forceps near the limbus, okay? Why do you want to do that? Because you want to hold the conjunctiva and episcleral tissue together, because if you do it otherwise, the conjunctiva will tear. Then the eye is moved, okay? The eye is going to be moved in the direction which is opposite to the one in which the mechanical restriction is suspected. For example, you're expecting that maybe there's going to be a mechanical restriction of the lateral rectus. Okay, so lateral rectus is restricted. That means when the eye is going to go in adduction, because of the restriction of lateral rectus, it's not going to allow it to go. Okay, so what happens here is the eye will be forcefully moved medially to look for if there's any restriction of the lateral rectus. All right, and force duction test is very important and it should be performed before every squint surgery. We'll see a video of it also.
This is Richard Allen at the University of Iowa. This video demonstrates force duction testing in a patient who has a left orbital fracture. Tooth forceps are used to grasp the eye at the inferior rectus insertion. On the left, a restriction is noted in the force duction since the eye cannot be placed in supraduction, while the force ductions on the right are free. At the University of Iowa, this video demonstrates force duction testing in a
Now what has happened here is that there has been a blowout fracture. In the class on orbit, I told you what is a blowout fracture, okay? So the inferior rectus has gotten entrapped in the fracture. Now because the inferior rectus is entrapped, it's not going to allow an up gaze, okay, for this particular eye. It's not going to let this eye elevate. So that's what they're trying to demonstrate here. When you see that when they hold the limbus on the opposite side and try to elevate the eye, it's not freely moving.
This is Richard Allen at the University of Iowa, who demonstrates force duction in a patient who has a left orbital fracture. Tooth forceps are used to grasp the eye at the inferior rectus insertion. On the left, a restriction is noted in the force duction since the eye cannot be placed in supraduction.
So you can see how
while the force
restricted it is in comparison to the right eye.
Are free.
Yeah, that's the end of the class. In case you have questions, you can post them now, or if you have more classes, you can attend them, and meanwhile also mail the questions if you want. We can answer them later also. Any questions, or are we good? Then I think we'll close the session. Thank you. Have a nice day.